And so let's turn to Connecticut, and I wonder if, Doctor, you can speak of some of the efforts underway to combat opiate abuse and specifically some of the new tools and resources under the legislation that Governor Malloy signed this past summer.
Yes, thank you. Good morning, everyone, and thank you to the Council for bringing us all together to have this important conversation. Connecticut, like many other states across the country, we're truly grappling with this opioid addiction, and we really appreciate being able to come together and hear about different initiatives and share some of our approaches and strategies. So the governor recently proposed, and legislation was passed in Connecticut that essentially does four things, and again, many of the things that we've talked about this morning. One thing in particular is it makes Narcan more readily available at pharmacies and also in many of our residential facilities. And we really thought this was important to be able to have just greater availability of Narcan, because already we're seeing a significant number of reversals, and so that's been promising. The other thing, though, is we don't want to just focus there. The bill also required that all prescribers participate in the prescription drug monitoring program. And really that's a statewide initiative. It's a program that we've had in Connecticut really for the last 5 years. But now there are more guidelines and rules around all individuals that prescribe these prescription drugs that need to be part of the monitoring program. And that can really begin to help with some of the doctor shopping, which we had seen some of that in the state. The other piece, and again, we talked about this this morning quite a bit, is just the need for greater education around the dangers of prescribing large quantities of opiates. And so we're offering increased education and continuing education programs for all prescribers statewide as well. And that's been a significant initiative, because what we're hearing back is that some prescribers weren't aware of some of the long-term behavioral health challenges that individuals can quickly experience it from a behavioral health and community perspective from many of these medications. And so that's been an important program. And then the other area, which we actually had our first meeting of our reconstituted Alcohol and Drug Policy Council. And so the governor's bill reconstituted this council to include individuals in recovery and family members and community members. And that's been really valuable. What many of our individual in recovery have told us is that, we have a cadre of 300 individuals who've been trained by the Connecticut Community Addiction, by CCAR. And that they are interested and would like to work with us around engaging individuals in emergency rooms. And so we're interested in replicating some of the programming in Rhode Island and other states that actually use individuals in recovery and collaborate with families to engage people in emergency rooms. One area of work that has been ongoing in Connecticut is really looking at our data. We have a ton of data, and so as in my new role as commissioner, I've been interested in sort of looking at what are some of our patterns around individuals, the points at which they access care, even follow-up. So individuals that experience reversals, what are the rates at which they're following up or engaging in services? Or individuals that are in detox services, what are the rates at which they're accessing MAT and other services afterwards? And so through some of our data initiatives, we're actually seeing that there are some gaps there that we're looking to intervene and engage, particularly around individuals accessing medication-assisted treatment after detox. And we feel that's an area as well where we can engage individuals in recovery to partner with us to introduce this treatment form to individuals who are in a detox or emergency room setting. So those are some of the areas that the particular bill addressed. There are other range of activities that on a statewide basis we're also implementing, and we recently developed a framework. We knew through DEMIS we have a lot of different activities going on, and I really wanted to be able to put those in a framework to be able to identify what are the buckets, or what are the areas of work, if you will. Some of my thinking was if we did that, we might then be able to see areas of strength, but also areas that may be gaps that we might want to intervene. So real quickly, what we're seeing is that we have 3 overall buckets where we're doing some of our work, and that is in terms of prevention. So to prevent opioid use, altogether. And so there we have a range of public awareness and public campaigns going on around raising awareness of the dangers of non-prescription use, whether it be through websites, through fact sheets, through videos that we're disseminating statewide, and really looking to get more information out about the dangers of prescription and heroin, or prescription opioids and heroin use. We're also partnering with our other sister agencies, with the Department of Consumer Protection, with Department of Public Health, with DSS, to develop a range of comprehensive strategies to address the full treatment spectrum from access, prevention, and recovery. Another area is we're looking to increase access to MAT and different community-based services and supports. What we're finding is that, again, once individuals are in detox, currently individuals in detox may or may not be engaged or accessed or exposed to MAT until after detox. We're really looking to expose and introduce individuals to MAT during the detox or process, and to begin those discussions at that point so that individuals can then connect afterwards. And then we're doing a lot of work around preventing overdose deaths. And again, this is increasing the availability of Narcan statewide, doing a range of training for our police departments, our first responders, and other family members around the use and value of Narcan. And so looking to get that out statewide. So, thank you.
Thank you. So let's look to Rhode Island. As we heard earlier, these issues and problems don't stop at state lines, because if you live in Fall River, New Bedford, you're as aligned with Rhode Island. If you're on the North Shore, you know, that market goes into New Hampshire, as we know from talking with Governor Hassan earlier this morning. So, Ms. Montero, you have co-chaired Governor Raimondo's Overdose Prevention and Intervention Task Force, created by an executive order in August, and you were charged with developing an action plan. I understand you just gave it to her on Friday, so hot off the press. Can you tell us some of the things that plan includes?
Certainly. So thanks to everyone for hanging in this long morning. As you've heard, the governor asked we've had a state task force on opioid deaths for a couple of years, and she repurposed that task force by executive order and charged us with developing a strategic plan within 90 days to lower the number of opioid deaths. Rhode Island is a leader, unfortunately, in opioid deaths. We had 239 deaths in 2014, which for a small state is alarmingly high. And our goal with the new plan will be to reduce that number by 1/3 in 3 years. Hopefully we can even outperform that goal, but based on our data, we think we can make that achievement. Some things to note, we see a lot of the trends that were discussed here this morning. So 50% of the deaths in Rhode Island in 2014 involved fentanyl. That's up from 37% the prior year. So we're seeing a spike in fentanyl-related deaths, and you heard a lot about that this morning. Not only does fentanyl increase the addictive quality of heroin, but it also really becomes a much more dangerous use, and the death results very quickly, even more quickly than Narcan can address in many circumstances. So this issue of fentanyl deaths is alarming. Our plan focuses on 4 strategic areas, many of the areas that you've heard a great deal about this morning. But much effort has been occurring in Rhode Island for a number of years. So our plan, rather than trying to encompass all of those efforts, in which case we would have a long plan like Massachusetts of 60 or 70 recommendations, we decided that the plan would really be the ceiling, and the floor of activity that we already have going on would continue. So not to diminish the efforts that are going on, we picked 4 areas where we think we can go above and beyond our current activity to have a real impact in death. And the first one is to double the amount of medication-assisted treatment that is available in Rhode Island. We already had a significant amount of medication-assisted treatment in 2014, we had 4,500 folks that had gone through a methadone treatment program, and another 4,600 people who had received another form of medication-assisted treatment, namely buprenorphine, but mostly to support detox. So we think we can do better than that, and so our plan is to double the amount of medication-assisted treatment, and most importantly, to focus on areas where it hasn't been readily available. So we really underuse buprenorphine in Rhode Island. In fact, less than 75 Rhode Island doctors actually are data waivered to prescribe buprenorphine, and as you know, the limit on how many patients they can treat is 100. I hear that's being addressed at the federal level, but in our state, they average 12. So there are a lot of reasons for this, partly because as primary care physicians, they are really treating only their primary care practice panel. And in our opioid outpatient treatment programs, no prescribers are prescribing buprenorphine, so we need to change that as well. So we're gonna focus this strategy on really creating a no wrong door approach for the use of medication-assisted treatment with some targeted initiatives. One is that we're piloting a Vivitrol intervention at our ACI, and we're also going to begin, we're one of those states, as you heard this morning, where when somebody enters the ACI, they come off of Medicaid and they receive no medication-assisted treatment while in the correction system. Then they come out and they're at great risk for overdose. In fact, over 65% of the deaths in Rhode Island occurred among people who had had a stay in the ACI in the past 2 years. And we know by our own statistics that individuals coming out of the ACI are at a 50% higher risk of overdose than other other people struggling with an opiate addiction. And this is partly because of the detoxification, the higher sensitivity that they have when they come out. So we're going to begin also a buprenorphine program at the ACI, and in my own department system, create an outpatient treatment clinic really targeted at people who are being released. We are doing some things at the ACI. We have recovery coaching at the ACI in our dry dock program, but we need to do more with medication-assisted treatment. And then to engage primary care physicians is a difficult thing, because primary care physicians really need a great deal of support to change practices around the use of medication-assisted treatment for opiate addiction. It's not just prescribing. They need to be linked to addiction medicine specialists. They need to feel support. They need some kind of grand rounds system that they can tap into. And they need to have access to recovery supports for their patients. So we are going to, we have asked 3 of our community health centers, who collectively treat about 6,000 to 7,000 people who are currently dependent on opioids for pain management and have developed dependency, even if they themselves don't identify that as an addiction. And we are enrolling them in Project ECHO, which is a program that is aimed at community health centers and provides telemedicine support through a community of addiction treatment specialists. This program is anchored at a community health center in Connecticut, CHC Incorporated in Middletown. I used to work there many years ago. And that program is provides tremendous support to the kind of practice transformation that needs to occur at the primary care level. We think once we gain experience with that, the translation of that kind of work, and we'll count on partners at Beacon Health Options through Neighborhood Health Plan, partners at Blue Cross and United in Rhode Island to really help support how we're going to move these kinds of practice transformations, which are a lot like what we did with patient-centered medical home,